Welcome to It's All Mental, a podcast from Everyturn Mental Health. Mental isn't a bad word. There's no health without mental health. We're here to talk about every high and low. No limits, just good conversations. Hello everyone, I am thrilled to be joined by Councillor Asha Craig. So Asha is a councillor in Bristol and is the Deputy Mayor, and she is an award-winning Deputy Mayor and Councillor and has led on issues on structural and systemic racial disparities. Asha is also a national thought leader in public health and has led things like Thrive Bristol, which is the 10-year mental health strategy for the people of Bristol. So this Black History Month, we are joined by people to talk about systemic racism, the things that are impacting access to mental health services from the Black communities. So, you know, there's statistics out there, Ashley. I'm going to start with some statistics before I open up to you. That Black people are 4 times more likely to be detained under the Mental Health Act than white people. I'm going to start with that statistic, and then I'm going to start with the first question to you, which is, why is it so important that we're talking about mental health and Black people?
Oh my God, where do we begin? We could spend all day on this topic. It's because Black communities are being poorly served by mental health services, and that they have done. I've been in this gig. I've been doing this gig all my life since I was about 18. Okay, and I've always said it feels like we're just on this carousel, on this roundabout. It's kind of like nothing is improving. Oh yeah, we need to do something about this. Yes, we need to put more resources, but the data doesn't lie. The data never lies. And it's no different in mental health than it is in criminal justice system, as it is in employment, education. The list goes on and on and on. And you know something? I always say to people, if you don't understand our lived experience, and I think one of the issues, particularly around all walks of life, but particularly in the mental health services, I've always said we're working with some young people who are dealing with serious violence. A lot of, for example, a lot of those young people have a lot of childhood trauma, adverse childhood experiences, and all of that. And I can tell you, time and time again, those young Black kids are saying to me, yeah, I want to see a psychiatrist. Yes, I want to have someone to talk to. But guess what? I don't want to talk to somebody who doesn't look like me, who doesn't understand my lived experience, because nothing hasn't got better. When you look at the system wide, we are underrepresented. We're overrepresented in the mental health system and acutely underrepresented in the organizations that deliver the services to us. So there, for me, I feel that even though there's a lot of research that has gone on, you know, where is the intention? The lack of any real understanding of, you know, the stigma that is attached to mental health, because that's the other thing as well. Our services come when it's too late. Because of the stigma that is attached to, even if you're Asian or Caribbean or African, there is a stigma attached to somebody having mental health issues. And so usually some African families, it's a case of, no, we're going to take him back home or take her back home and sort her out. No, she doesn't need to go and see a doctor. No, there's nothing. But trust me, I've come across so many different people with different stories about how their families and loved ones have reacted to them, you know, to them having a crisis. And I'm somebody who can talk from lived experience, because I am, you know, I have someone in my family who is bipolar, schizophrenic, has got schizophrenia. You know, I've tried to navigate what is a really difficult system to navigate. And if already Black communities are disadvantaged, even accessing mainstream healthcare services, let's not, when we talk about mental health services, and they are few and far between as well, because it's not as if there's enough resource, enough beds, enough, you know, support available to them. So, yeah.
A lot to unpack there.
I'm sorry, yeah.
It's really good information there, but I'm probably going to pick on a few things that you said there. So
sure.
the first one I would like to get a bit more information about, and I think people will be really interested in understanding from your perspective, is that cultural stigma. And I think, you mentioned there about people going, we can manage this in the home, or we can take them back to, back to another country or back to a home country. What's driving that cultural stigma, and how do we work together to break that down positively?
I think what you've got to remember, in some countries other than kind of Europe and the UK, mental health is, in some countries, is not a thing. They don't even understand what mental health actually is, particularly, particularly in those parts of the world where, in parts of the global south and other areas where they have lack of or less resources, healthcare resources, or even poor education. So people just don't even know what is mental health. They just think that, yeah, they're gone off on one and what have you, and just take a few pills and you'll be okay. But it's also a shame. There's a shame attached to that. And I can talk from my own personal experience, because, I have a member of my family who's really, really ill, and I have seen all of the um, family support just completely dissipate. The only members of my family who actually give a damn about this member of my family is myself and my daughters and my partner. My other siblings, my older siblings, auntie, nieces, nephews, all of them, they've just turned their back completely, and they pretend and actually, in some regards, hold people more accountable when she is in a state of crisis than when she is, it's kind of like, oh, she's playing up, oh, everything is really bad. And I'm like, do you not understand that she's actually ill? There's something wrong here. But they just won't even give an inch, yeah.
And do we deal with, that's probably the wrong term, but do we work with this through education? Is education the answer here, would you say, or is it just an appreciation of difference and then working around and with that difference?
Well, I think it's really important. I mean, whoever is delivering, I suppose it's an interesting one when we discovered through COVID, for example, and everybody sees things through the eyes, Eurocentric eyes, thinking, hold on a minute, the skin makeup of Black people is actually very different to white people, but actually you're being taught to become a doctor based on a Eurocentric perspective of the anatomy, etc., etc. And so it's kind of like only in the last couple of years that it feels like the penny is only dropping, and actually, hold on, we need to take this from a completely different perspective. So it's a combination of both. It's about education, both for those who are becoming psychiatrists or want to work in the mental health field. They need to have the whole story, not half the story, or the story from a Eurocentric perspective. People need to understand, and that's why, people keep banging on about, oh, we need more diversity. We need more diversity. The clients that are coming to you, okay, are from all different backgrounds. Can you imagine, like our migrant and refugee communities, they have a heightened level of mental health needs as we stand, because of all the trauma that they've gone through just to even get to these shores, let alone what was going on before they arrived here. So again, unless you don't necessarily have lived experience, but you need to kind of understand the kind of nuances. And I say to staff in the council now, when people come and sit down in front of you in your customer service, treat them as individuals. Everything isn't black and white. Just because it's written down in black and white, these are the rules, this is what you're supposed to do. Have some compassion, have some empathy, understand where people are coming from. But also, if you don't know, then like we're doing in Bristol, educating, providing staff with more information and understanding about the different nuances and the backgrounds to the different communities that you are serving, because you can't deal with everybody the same.
You mentioned as well around that that people get better when they get help from people who look like them. I think, and I think
maybe that's too blank a statement.
And I was about to caveat that by saying that that's but we do know and we do see that you get better health outcomes from people who are
who look like you. Absolutely.
Because and that's a fact. We do see that.
Okay.
And we recognise, but that's not always the case. That's not to say that somebody who does not look like me, it's not to say that if you and I were in a therapeutic relationship, we wouldn't get good outcomes. But we know that there's an understanding, there's a cultural appreciation that's different sometimes. The barriers there then around workforce development and creating workforces that are represented. So as an organisation at Everyturn, we are really passionate. We are striving. We don't always get it right, but striving hard to get a workforce that represents the communities we work within around the country. It's difficult, it's hard, and you really have to work at it. But what do you see as being some of the biggest barriers there?
Oh, well, I think the lack of qualified individuals who are coming through the system, because the other issue that we have is even in higher education, we are seeing a lot of potential talent and potential, psychiatrists and counsellors of the future dropping out of higher education because of the racism that they are experiencing in higher education. So it's been interesting when I'm looking at some of the government initiatives. I think it is around we need more educational psychologists, for example, and the government is saying, yeah, we need more educational psychologists because the needs of SEN needs are going through the roof. But the reality is that's going to take like 2-3 years to, if you're going to get the diversity, it takes time. You either have to be quite deliberate about wanting to kind of make a difference and doing some of the things that we've done in Bristol by being very purposeful around some of the programs that we have delivered for Black and minoritized communities, and off the back of that, opening that out to LGBTQ plus communities, disabled groups, and even white women. Some white women have said to us that they feel they feel they don't have the kind of they feel intimidated in their own kind of circumstances. So we've listened and we've expanded what is a scheme specifically set up for Black and minoritized groups. We've listened and we've kind of opened that up, but still made it majority. So the majority of the people who come through that leadership program and many of our programs are still majority. We've done 700 people. Some of them work in the NHS and have gone on to have stepped up into bigger and badder and better roles. Because that's the other thing. You need to have people who understand. And again, it's not about that Black individual who sits on your board and they're the ones who got responsibility. The responsibility has to come from the whole board, comes from the chief exec, comes from the chair, all the way down. So if you want to make change and if you want to be purposeful, then you kind of start with the commitment from the top, and then you work with the organization, you work with staff within the organization, because you've also got to bring them with you. Because I've had, over the years, I've done lots of different initiatives where white staff will do what they can to actually undermine some of the initiatives that you're trying to bring in, because they don't get it, they don't understand, they weren't ever a part of it, they think that people are being treated differently. But as I said, the data doesn't lie. Time and time again, the data doesn't lie. So yeah, more has to be done. And you can take what is known as positive action. If you know that you have a growing cohort of Black and minoritized clients coming through, and you can recruit. I need a Black psychotherapist, or I need whoever specifically to work with these groups of people because they have the skill set, the mindset, but then in turn they can then pass on, or then a part of internal training within your own organization as well. You know, I'm no psychiatrist. I am a complete layperson. I am just a politician, but I do kind of get passionate when I see people who have been left behind and you know, whose voices are not being heard. And I see it time and time again, particularly around mental health. The overrepresentation, as I said, in the mental health system, but the underrepresentation in terms of voice, in terms of representation through employment. And you can make some of those subtle changes if you know,
Commit to it and make a plan.
absolutely.
Yeah, and
Absolutely. Make a plan.
make a plan, have that positive affirmative action, and actually deliver and do it.
Absolutely. Absolutely. And don't be afraid. You know, like I said, bring the team with you. So if you're going to have a strategy, the staff should be part of that development of that strategy as well. So that when your board agrees this is the way forward, this is what we're going to be doing, it's not they're not caught by surprise. And remember, I always say, there will always be people in your organization who will, there's just someone there who will always try to maybe undermine what you want to do because they don't get it, they don't like it, or what have you, and they do very little or not very cooperative. But I would love to put my hand on my heart and say the vast majority of the people who work in my organization and in my authority, they really actually want to get stuff done. They actually want to make a difference. They do want to help all communities, regardless of ethnicity and race and their, you know, their background. So, yeah.
So bring it. Oh, sorry, I should talk over you there. Apologies.
That's
I was
okay.
going to bring it back around to your personal experience and your lived experience. I think this is really, really important for us to get some further understanding on. So you're living with a relative with schizophrenia and bipolar disorder. What's that journey been like for you as a relative, and as a relative of a Black woman, and as a Black woman?
Okay, so as a relative, it has been, oh my God, I have been in tears. I've been, it's so stressful. So and it's been a journey for me because this crisis that happened, it wasn't ordinary. It didn't even happen in the UK. The crisis took place in New York, okay, because that's where my relative was living. And this was maybe about 10, 12 years ago. This is the weirdest thing. I'm going to have to tell you that's the story, but I happened to be in Florida. My daughter was dancing at a World Dance Championships at Disney World, and I was planning to go home the day before. They just won their competitions, and yeah, everyone was happy. And out of the blue, I got a phone call from my uncle all the way here in Bristol, telling me that, oh, you need to go and sort out your sister. And I'm like, what are you talking about? Oh, I've had a phone call from another member of the family in New York saying she's been taken away. She's acting up. She's put all her furniture outside. She's done all sorts of stuff going on. Anyway, I put my daughter on a plane back to England, and I jump on another plane and go to New York. And it was like walking into, when I went to the facility that she was in, you know, the film One Flew Over the Cuckoo's Nest. That's how it felt. I was walking down this, I thought I was in this hospital, and then they said, oh, go up to the 5th floor. Went to the 5th floor, and then I walked down this very sterile white corridor, and then I was met with these 2 doors, and then when the doors finally opened, I find myself in this mental health facility, and as I look to my right, I see my sister, you know, shouting, carrying on, and what have you. And then she looked at me, and she literally came running to my arms and saying, get me out of here, get me out of here, get me out of here. And we're not going to even talk about the mental health system in America, just even navigating that and getting her on a plane and getting her back to England, because it was quite clear that when you suffer from mental health in America, everybody abandons you. Okay, my sister could have been left on the streets, homeless or what have you, and I think she would have nearly been there. But I brought her back to England to try and get her the help and support that she would need. I brought her here to England, and what you've got to remember is you can't force people to take medication if they don't want to take the medication. So even though the doctors had, I got her to a doctor, they tried to help her, but my sister was just not taking the tablets or anything like that. And the crisis was getting worse and worse and worse. And the one thing I didn't want to do was have her sectioned. So as a relative, as someone who actually cares, I'm doing my very best to kind of hold on to her. So I moved her into my house and trying to help her. But then it was getting too scary for my children. And one of my daughters came home from school one day and just said, Mom, I was really scared. I was on the bus coming home and I thought to myself, I couldn't help thinking, is auntie going to do something to you, take a knife to you, or do you? That's what she's thinking. She's not saying she would do it, but because she could see her behavior. And I thought, I can't have this anymore. I've got children in my house now. I can't manage this on my own. And I literally broke down at work as well. I was working for a local authority and I confided in my director for children's services, and she just said, you can't do this on your own anymore. You're going to have to either section her, but you're going to have to go and get help. Oh my God. And that's when the journey began. I realized there was no help. There was hardly any help other than having to get the crisis team to come in, and then actually, because I've had to section my sister 3 times over the last 12 years. And so, and as a member, as a Black woman, in my family, like I said, I saw all of the support in my own family, other than my daughters and my partner, completely evaporate. No one gave a damn. No one didn't care about her. They had very little patience for my sister's behavior. They just did not want to accept the fact that she was ill. And then as a Black woman navigating the system as well, and just seeing how poorly resourced it was, I ended up my sister ended up nearly 200 and odd miles away from me when the last time she was sectioned. There were no beds for her. There were no beds for women, hardly any women in the city. And I ended up having to travel. Oh my God, where was it? Was it Bury? Somewhere all the way up. It was far. And literally, me and my daughters got in a car and drove for 2.5, nearly 3 hours to go and spend 1 hour with my sister in this place. And because of who I was, and I have to say, it was then that I used my position, because obviously I'd been delivered the Thrive Bristol program, and I just thought, this is ridiculous. My sister needs to be closer to home. So what's the care plan? What are we going to do? How are we going to address this issue? So I'm lucky, because of who I am, that I could use my influence and knowledge to be able to get what I needed out of the system. But I can tell you, most of the people who look like me, they give up time and time again. I've got so many friends who are caring for people in the system, and they just feel like they just get a really bad rap. And I was always told, someone said to me, oh, Asha, whatever you do, don't tell anybody that your sister's actually going to stay with you, because once you tell them that she's going to live with you, then all of the services just put all of the headache on you, and they do very little. And that is very true. That was very true. The fact that even though I was trying to find her somewhere to live and all of that, it's as soon as the system knows that there is some support, they completely kind of abandoned. And I just felt like they didn't give a damn. And even more so for when I think about, and it's not even just Black patients, it's Black and white patients. Everyone is getting a raw deal, you know.
Taking race out of the question, we've got significant and sizable capacity and demand issue in the UK with our health,
Absolutely.
and particularly with our mental health system. And we've our demand is completely outstripping
But
the
yes,
supply.
the demand is through the roof. But what you may end up seeing is that we will still end up on the bottom of the pile. Who are the ones who are going to be at the top of the list? How are we going to ensure that there is equity in the way in which the need is addressed? Because that is the issue. It's also about equity and access and making sure that, and that's the other thing, just navigating the system. The reason why I set up Thrive Bristol is because I happened to I went to New York on a little fact-finding mission. I fell over Thrive New York and I thought, oh, this sounds really good. And I'd just gone into my role around public health. And because of what was happening with my sister as well, mental health was something I was really, really keen to kind of get into. And I went to New York and I met with the mayor of New York's wife and some of their colleagues, and they explained to me, because they just had this multi-million-pound mental health program, and what the Mayor de Blasio's wife had done is she'd spent a whole year going around all the boroughs in New York and talking to kind of local people, particularly Black communities, because she said to me, they have a daughter who had mental health issues, and she's mixed race. Okay, so the wife is Black, the mayor is white, but they are very, very privileged. They have money, so. But she said, regardless of whether or not I was privileged, she found it difficult to navigate and access the mental health system in New York. So because of her own personal experience, she said, well, if I have the privilege and I have the money and I find it difficult, how hard must it be for people in local communities? So she went around and talked to everybody, and it inspired me to come back. I had no money, I had no resources, no multi-million pounds, but I said, you know something, we are going to do this. We're going to have a 10-year program on mental health and well-being. Our one city kind of approach. We are going to work as one city and use the resources that we all have, whether we're the public sector, the private sector, the voluntary and community sector, and make sure over that 10 years we want 1 in 5 individuals to have had first aid training. We've got different initiatives around higher education, thriving communities, thriving communities, thrive for in schools. We've got quite a number of different programs, and one of the things I will say is COVID we also found so much more resources being pushed into the Black communities as well during COVID. It was there was a whole shift by the NHS and the health system, and actually far more money was invested in the needs of Black voluntary sector organisations. So we have a Black-led organisation in Bristol called Nilari, who does phenomenal work working with different communities. But again, they had been struggling for a really long time until there was a light bulb moment that went off for some people.
COVID was a stark, very rapid reminder of the health inequalities that face.
Absolutely.
It became very apparent very early on that Black communities were far more and far greatly affected by COVID, and therefore something had to be done.
Well, we actually did a rapid review. So before the review that London did, myself and the mayor, we did a rapid review. University of Bristol came out and did the review, and like you said, it clearly highlighted all of the health inequalities that our communities were facing, and COVID and the morbidities and all of that was just compounding the issue. And off the back of that, I think it was again a light bulb moment when people realized, actually, something, we really do need the help of the communities. If it wasn't for communities, Black and white communities, I don't even know if we would have really navigated COVID as well as we did. But I will tell you now, people from the Somali community, some of our Black carers and others, they said even the relationship shifted completely between the voluntary and community sector and public sector and the council, because of the need. It was quite apparent we needed them more than they needed us.
So how do we then? So final question before I move on to my penultimate question is that how COVID laid bare that health inequality and the fact that Black and minoritized communities were far greatly affected by COVID than white communities were. And that led to greater funding and greater collaboration and greater action.
Yeah, it did.
The same can be said for mental health.
Absolutely.
So how do we ensure that the same collaboration and funding is applied to the mental health needs of those communities in a similar way?
So again, one of the things we're really hot on here in Bristol is around collaboration, because we know that resources are very limited. So and that is what we have been pushing for. Like I said, we work as one city. Partnership is absolutely key. So it's no good trying to set up yet another organisation to work with this specific group of. What you can do is Nalari could be collaborating with one of the other mainstream mental health organizations. But like I said, it's all about equity. We're not there to just tick box exercise to help the white-led organization meet its targets. It has to be a true collaboration and a true partnership. And we have seen that time and time again with so many other different initiatives. And like I said before, we need also allies. One of the great things that one of our officers who helped me deliver the Thrive program went on to work for the NHS, and she is still working around mental health. She is an amazing ally for us and has been able to educate herself, make sure she's aware of the numbers, and even if we're not in the room as Black people, she's advocating and so that's the other thing as well. We may not be always in the room all of the time when the decisions are being made around funding and resources, but yeah, we are really pushing for a lot of collaboration and partnership working, and we've done that we made available £4 million of post-COVID resources to support organisations to kind of get back on their feet. But again, an emphasis on collaboration was going to be key for some organisations to survive. So that's what I'd like to see from your own organisation, maybe seeking out a potential partnership and collaborations. Yeah, and you are, and most of the time, many of these organisations are small grassroots community led. Big organisations like yourself who can access and do all the funding bids and all, because that's the other thing. It's like you expect the smaller grassroots to somehow elevate and go through this whole commissioning process. I haven't got time for that, but what they are bloody good at is actually, excuse my French, but what they're really good at is getting stuff done and directly working with the communities on the ground. And if you can help to smooth that process and kind of take that on without those organizations feeling that they're going to be shafted, because I think that's been in the past. People have just felt it's just paying lip service and they're not a true partner.
And that's real key, isn't it? It's not tokenistic. It's not just paying lip service. It's about true, deep and meaningful partnerships that are about collaboration to make a difference for communities, whether they're Black, Asian, gay. It's about making that meaningful change through working together in partnership. So
absolutely.
My last question, then my final question, and I always like to end on a message of hope.
Okay.
I think it's all too easy in these conversations to always focus on the things that aren't so good. So what's your message of hope, or your message of hope for change with regards to mental health and the communities that you know so well?
Yeah, my message for hope. My message is I think for Black communities, I think we have to embrace. I think again from COVID, we're seeing more and more people from our communities actually acknowledge that they are suffering. Men in our communities as well. We've now got lots of men who are talking and lots of kind of talking therapies and stuff like that. So I have a lot of hope. I think it's a case of what we need to do is we need to address the stigma that surrounds our organization, our different communities. And I think in addressing those stigma and making it fine to not be okay, to also understand that there are people out here who have got you and will support you and will help you. And my hope, as I've said with our Thrive Bristol program, is by the end of that 10-year program, we have more individuals, ordinary members of the public, who are equipped to actually maybe help and deal with any crisis that they come across. Because I think for me, one of the reasons why I wanted the first aid, mental health first aid training, is because I was sitting on a bus one day, and a woman came onto the bus, and it was quite clear she was having a crisis. And the way how the bus driver really dealt with her, even when people on the bus were getting all irate, oh, hurry up, get on the bus, whatever. But he was so patient. And then after he got her on the bus, he took her to the next bus stop. She came off, she came on. But 3 stops on, and then she finally decided that she got to where she'd got to. He didn't take any money from her, but he was just so understanding. And we had a meeting. As I said, we work as one city, so that managing director of the first bus was at a meeting, and I went up to him and I said, oh, do you give your bus drivers first aid mental health training? He says, nah, sure, I haven't got time. I said, well, I want to tell you about this bus driver on your number 6 bus at this time. I need you to commend him. But I said, I realize that your staff are interacting with people all day, every day. And if he hasn't had any training, but if we could deliver training to frontline staff and others who interface with people in a crisis, oh my God, yeah. So yeah, my hope is that we'll see a lot more empathy, a lot more service delivery, and lots more resource going into mental health provision. Because as you said quite rightly, we've just seen mental health, the needs of people in mental health needs go through the roof since COVID, and it's not going anywhere. And it's getting younger as well. So that's the other issue. We're contending with a lot of young people who who've made it clear that they may need help. So yeah.
That's a conversation we could fill another half an hour on in itself, isn't it? So
yes, it is, Adam, it is. But really grateful that you're even putting a spotlight on this as well. And like I said, anything that I can do to kind of help you or any other organization. I'm in the business of making things happen, getting stuff done. And so anything that I can do to help,
you know where we are. Well,
where you are.
Contact details are there for people to reach out. So Asha, I'd like to say a huge thank you for your honesty and for your candor and for the discussion, because it's been ridiculously insightful. Thank you so much.
Okay, well, thank you very much, Adam.
Thank you.
Thank you for listening to It's All Mental, a podcast from Everyturn Mental Health. If you enjoyed this episode, remember to follow, rate and share. See you next time.